Didn't get that as the intro.
Good thing this camera's to my left.
That's not just his creepy catch a predator voice. That's damaged vocal cords right there.
You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
So yeah. Can I make this full screen? No, whatever. Yeah, updates. Anything new? Last podcast. It's Trent. Yeah, we got his farewell dinner tonight. Last meal before death row. So what'd you pick? Death row meal. What are you going with?
Just ice cream. Probably just like
2 nights in a row.
Just a bunch of ice cream.
Yeah. Okay.
Pancakes.
I don't think we're going to the right place. Yeah, so Trent's last show, well, I guess he'll be last day's tomorrow. Today's a Thursday when we're recording this, so we're going to hit a dinner tonight. So we'll miss you. Well, let's put you on the spot here instead of doing it on Instagram.
Oh, man.
And then we'll post it from here.
Wow.
So what's one of your biggest takeaways from being here at the farm, besides learning the idiosyncrasies of Mr. Alex Coleman?
Yeah. I think just like being more confident in my assessment and treatment all the way around.
Mm-hmm.
Truly learning how to look at function and treat function, I guess.
Mm-hmm.
Not just like worry about pain.
Yeah.
Which I know everybody talks about it, but until you actually see somebody do it every day, day in and day out, it's kind of hard to figure out exactly what they mean.
Unless we just say, hey, go shockwave them. And then we're like, yeah, whatever. Yeah. I mean, I appreciate that because hopefully that's what we're doing. And as one of my mentors says, Brett Winchester, get kicked in the teeth long enough, eventually you just say, oh, I'm treating function. Then you kind of don't care as much, even though you still are. But you're just like, this is what I'm doing. And it makes your life a lot easier. But it's like you said, it's a lot of lip service sometimes. But yeah, that's what I'm doing. And you get caught. Like I get caught sometimes. Like I'm just trying to make them feel better. And sometimes you got to do that. So if we're talking about knee cases, the one we weren't going to talk about today was somebody that I think needs somebody to talk to about their knee case, somebody to rub their boo-boo a little bit based on what they think's going on with the boo-boo. And then, yeah, I think that's a big part of it. And we started on this whole functional route, and it came around a weird turn to a little bit of a breakdown visit with some crying. And yeah, and then I was like, okay, I'm gonna handle this a little bit different. So knee case that I don't think we were going to talk about it. And I was like, I don't really think your knee has a big problem anymore. And you can call that chronic pain, but I don't even know if that's a good categorization for that patient. I think it's just that they had a bad college training room scenario going and had been treated by multiple people. I just think stuff got messy. So yeah, to kick that off, let's actually start, if you don't mind, with your case. He's over here texting people about golfing. Now he's got a new driver.
For the leprechaun.
Yeah, find him on tour 2027.
But Seth's got a good case because it's a abnormal case. Yeah, and I don't even really know what you're doing with it treatment wise at this point, so I'm interested to hear.
So that's the other fun thing is I haven't really gotten to treat it, which we'll kind of get to that as well. But junior in high school, I think she's 16 or 17-year-old female. We got a text from her coach one weekend saying that her knee was swollen. Her left knee was swollen on the outside, had no trauma done to it. She just was, like the normal like diving that you do in volleyball. Woke up the next morning and noticed that her knee was just like swollen. It was pretty, she said it was also kind of red. And they also mentioned that there was like a rash around it. I didn't get the rash whenever it came into me. Okay. So that's kind of what I was like the forefront of what all I was told. So she shows up and there's like a little nodule underneath her like left kneecap. It's the lateral aspect of it. And it's pretty tender to touch. But in my assessment originally, I had only found that like Thessaly's, right? So like bent knee twisting on it was the only thing that reproduced any of her pain. She could kneel on it. She could jump up and down. She could do anything and everything. She's also super flexible. So, I mean, she passes like pretty much all of SFMA and any of my like movement assessments, like with flying colors. So then it's kind of like, okay, well, why did this thing pop up? She had at one point talked about that she had like dislocated her knee before, like the patella had actually like gone out one time. She like extended her knee, right, popped it back in place. But that was like a year or two ago. But she has noticed that as the more she plays, she has started having more and more like lateral knee pain. Just she doesn't notice it during the games. It's only when she gets done with the games. So I originally went after some knee extensions because that's the only thing that really was limited was extension of her knee. Nothing with low back. I mean, couldn't reproduce anything with her low back. She's again like she's super flexible, so I mean she crushes everything. She has some trigger points around the quad, but none of them reproduce the same pain that she was feeling. And also, we can go super local, and there's like a mass there, and you push on it. It's kind of like it's tough not to be like, yeah, I got to chase function. It's like, well, that's the thing that's in front of you that's causing it. So I think I taped it that day, and then also sent her home with knee extensions because she still had to play another game because it was a 2-day tournament I saw on her Saturday. She still played on Sunday.
Yeah.
So my goal was just to kind of make sure she could try and get through it before we went too heavy on like needling or anything like that. Came in 2 days later. It was a little bit larger. And also said that like walking around now is a little painful, but was not painful to jump, play volleyball or anything like that. So I sent her out for an MRI just to rule out anything that's there. Because when you start seeing something that's kind of like red, a little warm, right? You start kind of thinking like infection is like one thing that I need to make sure she doesn't have. And also she wears like knee pads. So making sure like landing on things, she's not having some type of, MRSA or something like that that's going on inside the knee that you just not catching because you can't see maybe where the portal of entry was at. So that's kind of what I sent her home with, but she didn't have any nausea, didn't have any vomiting, no fever, nothing like that. So it was kind of low, but also just to make sure I checked it off. Got the report back, and she had a synovial cyst that popped up on the outside of the knee. That's kind of what you could see underneath the kneecap. And I want to say it was like a 2.5 or 3 centimeter cyst. I mean, it's pretty large, big guy. So yeah, we kind of just talked to the mom about what all we need to do with that. Which on the MRI, which I know we had talked about at one point, some of the reasons that you create a synovial cyst is obviously to be a protective barrier, just like any other tissue. So with the laxity that she has in her tissues, she's probably having some like recurrent small knee dislocations that she doesn't realize, which they typically go laterally. So she's probably just bombarding those tissues over and over and over again. And her tissues are like, hey, we got to do something about like maybe one, stabilizing this kneecap. So we're going to put a little bolster up, and 2, protect anything that's on the outside. So that's kind of why that synovial cyst forms. So we looked at the MRI as well. You can see that on her femur, it's pretty shallow. I mean, it's pretty flat across there. So there's not really a pocket that the patella really sits in, or that little trochlear groove. There's not really anything there. And also the kneecap itself is a little less triangular in shape, is a little bit flatter, which we kind of talked about lends itself to, she's probably going to potentially have those continue because just structurally it sets her up for it. So then you get down to, okay, well, what are you going to do for the rest of the season, right? Do you pull her and it's like, hey, she for sure needs to go have a consult with an ortho? Or number 2, are you like, hey, how bad does it hurt? It doesn't hurt her during her games. It doesn't really hurt her any other time except when she gets done playing. Doesn't feel it at rest, doesn't feel it any other time. So it's kind of like, do I pull her when she doesn't have any pain while she's playing? So then you go, okay, well, we could maybe get a brace that has some type of like patellar stabilization piece on there, right? How effective is it? I have no idea, but at least it's something that is external that can maybe help to get her through the season. And so I explained all that to her mom, and her mom's obviously like wanting to avoid surgery as much as possible, but also talking to her about like, I get that we want to avoid surgery, but at the same time, just looking for like long-term health. I don't want that to continue being an issue.
Mm-hmm.
And so I sent her home with, I'm trying to think. I haven't seen her in a few weeks because her mom was just like, she chose that she just wants to get through the season. They bought the brace, and then she's actually coming back in today to get seen now. So I'm trying to think of, I can't remember what all I did that I sent her home with. But I think it was like some single leg differentiation just to work on like foot, hip, just stabilization as much as we could. And then I think I also worked on some like, I think I sent her home with some pogos as well, just to kind of work on some stiffening of some tissues as well around her knee and ankle. But that was pretty much it. Just trying to keep it pretty basic as well, because since her mom was like, well, we'll just do the brace for right now, and then we'll consider other things down the road.
Mm-hmm. What are your guys' thoughts on like you said, like a cyst is kind of tissue that's being bombarded, or in this case, we could literally say maybe for one of the rare cases that there's like patellar tracking issues just because of like how the knees form, like dysplastic change. What do we think about like that's basically a callus, right? You're just running into whatever fibrocartilage or some other tissue that kind of acts like an internal brace almost at this point, right? Like the kneecap's running into that big cyst. So then I think it's kind of an interesting conundrum of like, if you just, because I think that's pretty minor surgery. I mean, you're removing a cyst. That should be like minor incision. They drain it. So like you're cutting it out through probably a tiny, half-inch hole, if not a quarter-inch. But I wonder if like you would see like a dislocation or something. So yeah, I was just curious. Like, I wonder how much that would affect it. I don't know. Did you guys, or had you thought about or discussed with parents, or would you like any, because I assume she was kind of hypermobile, right? Which you're going to have more likelihood of collagen disorder, cystic formation, but like other autoimmune things, knowing that that was also like red and hot. Because yeah, you can have obviously, a true, I don't know, I guess if it's a cyst, I guess that's different than, some sort of itis. But if it's red, warm, and maybe she had a rash, so skin thing, like maybe she's having an autoimmune issue, and like that might be a bigger part of the like why it hurts, why it flares up or gets bigger sometimes. Were there any other like health issues like known like that were discussed? Like sometimes you don't get, especially a teenage girl, GI distress, stuff like that. Which
So we also talked about that one. The mom says that she has Lyme disease because she got it chronically because she has Lyme disease.
Oh boy.
So
if that mom is listening and just listen to me say, oh boy, here's my take on that. There is an overabundance of diagnosis in the functional medicine world, in particular Lyme disease, chronic recurrent Lyme disease, where we test for antibodies. My big question on that one is, if you just look at the data of the diagnosis of people, it's supposed to be more Northeastern driven, right, based on the tick population. But if you looked at the people who spend the most time outdoors versus people who don't, and then the diagnosis skew, it's people that don't spend much time outdoors, which makes no sense to me. So we're either not very good at understanding what like the test is testing for, or my take on this is we're diagnosing stuff wrong. It's wrong diagnosis 90% of the time. So like I think of Steven Ranella, if you guys know who he is, meat eater. Like he talks about like, I legit got Lyme disease. Like he thought he had mercury poisoning from eating too much fish because his hands and arms or legs and feet were going numb, or legs and hands, whatever. Going numb. And he's like, yeah, I was having like visual disturbances and like headaches and stuff. And he goes, I didn't know what was going on. I thought I had like Giardia or something, because he's always backcountry camping. And then he went and he's like, oh, I tested positive for Lyme. I had to do like, I want to say 6 months antibiotics or something. Mm-hmm. He's like, yeah, it all went away. It's like, that's Lyme disease.
Yeah.
So this like low level, and again, I'm going on a tangent, but for a reason, brain fog, I'm having like joint pain. I mean, I'm just being honest. I know this is a 14-year-old girl. It sounds like you didn't get Lyme disease to create hypermobility and all these things. You are more likely to have autoimmune issues if you're in that kind of phenotype. And I think that's good to understand. And then the second thing would be, there is no genetic pass on ability outside of genes that would create bigger inflammatory responses, different immune reactions to something once we had it. But that would also mean that she had to be exposed to Lyme disease from a vector. So that's my tangent on, when we say these things, we got to make sure, could it be true? Because again, I don't know if you know the parent's diagnosis of the kid, or if the kid's even seen somebody. Because in my opinion, like that's damaging to the kid, and I don't agree with that. So I'm not a fan of that. Yeah. And I'm not trying to beat up the mom, and I have no clue what the mom scenario is. But to say, have you ever had a tick bite with, bullseye rash with immediate symptoms afterwards? It'd be really hard for me to just say, oh, those antibodies test positive, because I don't think we're good. Yeah. I go down a big rabbit hole. But anyways, yeah, it is what it is.
I did not address it.
Yeah, I wouldn't have either.
I felt like
unless
it
they
was
hung everything on that. They're like, this is part of that. I'd be like,
and it is something that I probably am going to have to talk about maybe
Yeah.
today or at some point, because a lot of things I still treat the mom. And
but the mom was a patient first. Okay.
No, the daughter was a patient. I got the mom after I treated the daughter.
Okay.
And then I got another daughter of hers, and I'm supposed to be seeing one of her sons as well.
Mm-hmm.
So it's a tricky one because like I've gotten a lot of referrals from treating the family, but also like not just like bashing the entire family line of like, maybe we all don't have Lyme disease.
Right. But I think, again, you have an ethical and moral responsibility as a physician. So if somebody's being told something that's not true, and you think it is kind of like, in a way, why am I blanking on, if you pretend your kid's sick, Munchausen. It's like a little Munchausen type deal. I think that's like damaging. At some point, you're like, hey, they have Lyme disease. Like, what are you telling a kid that for? That maybe it was never been tested or doesn't have it. Because that's no different than telling a kid they have, I don't know, ADHD, and they never really been tested. You're like, oh, there's hypers. Like, that's a very different thing. And you're like, well, how do you test for it? Yeah, it's a questionnaire. But then you're like, okay, there's a very big difference from somebody who literally can't operate in a normal, like, day-to-day job, school, versus somebody who taps their leg like that all the time and snaps and sings. Like, there's anxiety, there's ADHD, you know what I mean? Like, that's damaging to give a label. It's no different than what we talk about of like, oh, you have, Achilles tendonitis. It's like, do you? Let's be sure before we tell you that, because then you're going to go Google that and treat that. Or is it like your low back referring pain in your Achilles? Or it's not tendonitis, just like it hurts a little bit from sugar point. I don't know. But I think it's no different than that.
Which, again, I think that's something I'm going to have to address at some point, because it's also one of the reasons that the younger daughter that I also treat, she got pulled from public schools to be homeschooled because she needed the extra rest, because you're more chronically tired when you have Lyme disease.
So wait, this is a different daughter?
Mm-hmm.
Oh my God.
I treat 3 of the family members right now.
So again, if they're listening, I'm not beating you up here, because I would put this disclaimer out, because maybe somebody listens that they're like, oh, that's my case. We're not beating you up, but like, there is no way it is genetically passed. You may be able to pass antibodies, which would actually improve your response. I mean, that's epigenetics of like viral loads and bacterial infections. There's no way. Like I said, you could have genetic variants that make your reaction different to diseases, but the disease itself is not a genetically like destined disease. This episode of the Farmcast is brought to you by RockTape. Use code FARM20 for 20% off their core courses at rocktape.com. It includes everything from kinesiology taping to vibration and mobility training. We use RockTape here in the clinic. We use all their tools. We've done all the training. It's all worth its weight in gold. So again, use FARM20 at rocktape.com for 20% off. And that's, yeah.
And the way that I went around some of those topics was I discussed, because she's also like pretty pale, right? So I just asked, like, one, I was like, how well are we sleeping? I just hit some of the very basics of high school females. I was like, how well are we sleeping? How well are we eating? That we feel like we're always chronically tired, because I know you have a lot of games and stuff like that. For volleyball, you have a lot of practice. I get that. How well are we doing those other 2 things? Obviously the eating is not the greatest. She's like, she sleeps really well. She's like, she can sleep 10 to 12 hours a night. No issues.
Whole week for Alex.
That is, he'd love that in a week, actually. The other one was, since she was pale, I also asked, I was like, how much are we actually getting outside? Because I do know that another thing, especially for my females, is like low vitamin D can also be a big contributor to some like low energy levels as well. So I was like, how well are we doing some of those things? And the mom was like, well, she's going to have low vitamin D because it's chronically known that you're going to have low vitamin D with with Lyme. And I was like, well, if I told her, I was like, if we're going to go off of that, then we should be doing something about that.
Yeah.
At least looking in that realm.
I mean, did you ask, like, have they tested any of the girls? Like,
I did not go on that.
because what that test, what, Western blot? Is that? Yeah.
Yeah.
Yeah. So, yeah. Yeah, I don't know. Yeah, like me at my stage of my career, if somebody's telling me that, I'm addressing it right there. Because I'm just like, you're in charge of your kid. You brought them to me for their health. You're telling them something that, if I can determine it's absolutely not true, that's absolutely not true. I mean, there's not an opportunity for it. If there's an opportunity, I have to kind of be like, okay, like I might still bring it up with a caveat, but with that, I'd be like, that's just not how it is. And if they decide not to come back, I'd be like, that's my job at this point, is not to keep them here necessarily. It would be like, what you're telling your kid's not true. And like now you're saying that is part of what we're treating. Like, oh, this low energy and stuff. It's like, yeah, like most kids nowadays suck at the basics and eating, sleeping. Oh, you sleep enough? Okay, your diet sucks. You don't get outside or take vitamin D. That still doesn't change that you're not outside. Like, yeah, I don't know. That's a tough one. Yeah, because then we even go down the pathway of how old's a girl with the knee issue.
16 or 17.
So talk about low vitamin D and how it's going to like play around with their hormones and things like that at this age, and how then that can contribute to cystic formation even more or worse, or change it. So those kind of things do matter. And then if we, like I said, everything's led by this like, thought pattern around Lyme, that gets tough. Yeah.
That's why I brought it to the table.
Yeah, it's fun.
Because it's
I'd like to know, people, if you're listening, like, how would you handle it? If somebody's got different thoughts, like, and I'm not saying I know everything about Lyme disease by a long shot, but I was told that I have low level, titers when we test this stuff. So as my wife with a functional medicine doctor, I've known tons of people that have. I've known people that actually have Lyme disease personally, and people like we were talking that are celebrities. Yeah, I think it is kind of like fibromyalgia is maybe a little bit different now, but it's like that. You're like, oh, you have all these symptoms. We know that you can have these symptoms with this thing. People will show up with antibodies to this thing. And I think that's, people are like, well, how do you have antibodies if you don't have it? How do people have, Epstein-Barr virus, antibodies that have seemingly never had mono or something like that? And then that's what they test for later in life for autoimmune things. It's like, well, I was never diagnosed. So they're like, oh, you probably had it. You just didn't get diagnosed. That's what we're just going to go off of? Like, I don't know. And then we treat that thing. That's where I have a big problem. If you're just like, oh, that's kind of weird that you have that, and then you don't address that, I'd be like, okay, cool. That's a good thing to know, maybe. Yeah.
I just know that based on the guy that you talked about, like how much healthier he's like gotten, like after the antibiotic stuff. And also our buddy Steven, that was at Logan. He also legitimately got Lyme disease, but he got bit by a tick because he's just a guy who like goes camping.
Yeah.
Had a tick bite him, got the red bullseye
like
rash.
Napalm of antibiotics. Like there are.
Yeah, he had like 3 to 6 months or so of like where he was like heavy antibiotics, and now he's like the guy who's eating like raw meat.
Yeah.
And you're like, that shouldn't be a thing. And
yeah.
I look at him and I hear that guy, and then I look at the family I treat, and there's a large difference.
And again, we always say most likely. The least likely thing is that the Lyme disease is the main factor of a low energy thing. And I'm game to be wrong, but like you would have to prove that to me unequivocally with like testing and like, how'd you get it? Oh, I dealt with an initial thing. Why aren't we treating it then? If we know what the treatment is, that's the whole thing. So when we look at this again, functionally, we can do a quick segue into functional medicine. What's the most common treatments for this like chronic recurrent Lyme disease stuff? Everybody hinges on what? Phase 2 detoxification. You need to clear those pathways because it's basically bombards your body. That's why you're lethargic. And that's like, why? That doesn't make, okay, so we know how to treat it. And I know they're saying, well, it's in your body and you're just kind of having a memory, like you're having an immune reaction, right? Don't get it. Doesn't make sense. At least to me.
Yeah.
I don't know. Same thing with EBV. Like I just think in this functional medicine world, it's kind of like if we had to, create a parallel to our world in musculoskeletal realm, it's like, it's kind of like, people are going to beat me up. It's like applied kinesiology. You're just making shit up. It's not that your muscle test wasn't weak. So that's true. It's not that you don't have the antibodies to EBV or Lyme. The correlation of this muscle test, it's what I do treatment wise. And then that true test, right? The test being what I do for treatment. I think that's where the false is. You're creating a very loose, if no correlation, then acting on it. I have a problem with that. That's just me. Bring it. Attack me. Applied kinesiologist fans. If you got chronic Lyme disease and you're like, that's me. I mean, I'm thinking of our old massage therapist, and she got knocked out like quick because of like chronic Lyme. But she also stated that she had an acute episode and then had this massive flare up years later. I won't deny that, because you literally can say like, dude, I was 6 months antibiotics and it was terrible. Like that was one where I was like, oh, and later she was like, I was really stressed out. I think it just flared up. I could buy that. Like I can't buy a kid that's never had it.
I know the mom is on a lot of different supplements, and I do know that she's also been on antibiotics for 2+ years.
For what?
For the Lyme.
Who's doing that?
Apparently is it her rheumatologist maybe, or whoever is treating that?
Yeah, I've got one that's been on several rounds through different clinics, several years.
Again, maybe I poorly understand it, but I don't know. Don't know. Doesn't make sense.
Like she listed out so many different things to me. I mean, I just had to have the recording going, because like I didn't. There's no way for me to be able to. She didn't have enough room in our intake box to write all of it down.
Yeah.
And also explain how much of each one she was taking.
I think my approach may be, if you're like, this is going to be like, you're going to burn a bridge. It's like, you really lean on the fundamentals, and like, that's what you dog them on. So instead of dogging the disease state, right? Like, hey, what's your diet like? And then like really try to pin them down. Like they're like, it's 6 out of 10. Why is it 6 out of 10? And then if like, I sleep, it's like, you might be in bed that long. Like, are you actually sleeping? Like, have you ever tracked it? Like nail down hydration, sleep, diet, and be like, I want you to go all in on those, and then prove them right or wrong. And again, I know that's hard, because like, you don't know if they're really doing it. They're just telling you. But then say like, how have you felt? Be like, in the face of everything else he told me, that's what I'd still go with. Now, if you feel good enough that you feel like you don't have to take antibiotics, like, then at least you've shown them a change that's not correlated to what they're bringing to you. No different than if somebody comes in, they were told they got, I don't know, an atlas subluxation, like Trent was telling my patient yesterday. We're joking. And do I address that, or do I just say, well, hey, we're going to treat this. And then if you get change, then you say, hey, we treated this, we had change. I'm not saying that's right or wrong. Just we're going this route, and like, do you feel better and is function changing? Yeah, cool. That's what we're going with. Maybe you never address it. Maybe you get to know them well enough. You're like, well, that's kind of hooey, in my opinion. Yeah. Interesting case. Mine's a little different than that.
I hope so.
But still kind of a little confusion from the patient side. So I had a patient come in a little over a month ago now. Super nice lady in her 60s, had a partial knee replacement, which in her case is basically just a fake patella, right? With some supposed realignment stuff, which I'll talk about all that here in a second. Back in February of this year, or January. And then she did post-op PT for, I think, just 6 weeks is what she said. I'd have to look at the note. 6 to 8 weeks. For the month after that initial post-op PT, she's like, I felt really good. But she never left PT doing any like weights or loading. It was just kind of general range of motion, some stabilization stuff, but literally she never did a lunge, never did a split squat, never did a squat. So then she goes, then after that, I tried to get back into working out, and it's kind of been a roller coaster. It'll get kind of better, but not gone, and then worse. And now it's slowly just progressed to worse. And I was like, what's worse? It just kind of aches and hurts all the time. It hurts going up and down stairs, especially going downstairs. So when we hear that kind of thing, my first initial thing is not injury, especially in her scenario. It's like, you're probably just not very good at going up and downstairs. That's, what do we say, weakness, or how you're doing it. So we started talking to her. She's a pretty healthy person. Like, she's super active. She's able to play tennis or pickleball and golf and all this stuff. Wants to be as active as she can. Like, she's motivated, wants to do everything. Big scar, obviously, down the middle of her knee. So the first thing after we're talking, and she moves awesome. Like, she didn't have a whole lot of things where I'm like, oh, this is like standout. Numb over her scar. I'm like, okay, we can change that. So why would we want to change that? If we can improve feedback over that scar, you're going to improve feedback to your, a spinal cord, then your, sensory motor cortex. But then same thing with her. I was working on it, and then she was kind of the person that's a little grossed out to touch her scar, right? With a lot of our knee patients. And I was like, you're going to do it. Well, she didn't. Some people are like, oh no, she didn't have a problem with it. I was like, I'm going to have you do it. So you're making a physical connection of like, you do it. Cause she's like, well, can I use a tool? I go, no, just use your hand. right? She did that. I would say as I saw her 2 or 3 days ago, she's like, it's probably 90% back. Like it still doesn't feel perfect. And then from like skin movement, like over her patellar tendon, it was just like stuck. And now that moves awesome. So that's like, that was my biggest thing with her. I was like, I think we need to improve feedback to decrease pain because no positive orthopedic test. Knee range motion is absolutely perfect. Her patella glides and moves all around. The real reason she came into me besides the pain was she had went back to her surgeon and they wanted to do a revision surgery, not a full knee replacement, a revision to work on her patellar tracking because her patellar tracking was off. It wasn't like the lady can squat and lunge and like we worked on the nuance of it, but like it, yeah, with no pain. Unflex, she's pretty flexible. Full flexion, no pain. Full extension, no pain. No, nothing creates pain in her knee except when she's going up and down. Like in the office, we couldn't create pain. We did lunges and stuff. She goes, I can kind of, it's tight, but no pain. And then the longer she's on it, so going downstairs at the end of the day, right? All these things. So I was like, and I told her that confident. I was like, dude, I don't know if you needed the surgery to begin with. I don't know. And then I told her the story of my stepmom that they wanted her to have the same surgery that she did, a partial knee replacement with some sort of realignment. And I basically just told my stepmom, like, that's a kind of archaic surgery because partial knee replacements don't have a great success outcome rate, which here we have my grandma, here's this patient, like, all these people personally, plus the statistics. My stepmom, like that surgeon wanted her to get a knee replacement. She didn't want one. He goes, well, here's the second option. So it wasn't the best option. This lady, I don't think she needed this surgery in the first place because her knee moves like a peach. Now, subpatellar, I mean, ton that you got crepitus in your knee and, a bunch like, I bet she had a little degenerative change. I bet it hurt a little bit. And I'm just being honest. I don't think the surgery, I don't know. I have no clue. I didn't see her, so I can't say that. But based on what I see now, I can't imagine that was the case. So basically, kind of reorganizing feedback through scar work. The bottom of kind of like the bottom quarter, both her quads are just stiff as bricks. It's like you can tell she hasn't gotten a deep knee flexion loaded for a long time, right? It's just stiff, full range of motion though. So you're like, okay, that's just kind of how she's operating. So I'm doing some soft tissue work in there, which she's like, oh, that feels really good, even though it hurts. Immediately have her start doing like body weight, like front foot elevated split squats. Just like, hey, load knee flexion, get it moving. And like no pain. And she'd come back. She goes, it's a little bit better. It's a little bit better. And then literally, I think I saw her 3, maybe 4 times. I think it was 3. I was like, you need to just go next door to our gym and start working out. Like you need to start loading this thing. And I go, I think and she agreed with me. I go, I just don't think you did enough in PT, right? You just didn't kind of go hard enough in the paint. She wanted to do that. We kind of had some logistics stuff where she's going to be out of town and didn't get in the gym. So I saw her again one more time. She's like, how do you think I'm doing? I was like, how do you think you're doing? Doesn't hurt going up and downstairs. She goes, maybe a little bit again towards the end of the day. But she goes, I can do it and I don't think about it. That was our big functional check for her. She was saying the numbness, tingling, or whatever around her scars better. And then she just wanted a game plan while she's going to her daughter for the birth of her second grandkid to just like do a circuit, like get stronger. And I was like, oh, cool. So the reason I want to bring this one up is being, as you started with like treating function, her function was really good. Besides like, so I talked to Tim Brown yesterday and he kind of has, I was like, do you have a hierarchy of just general things? He goes, this is the way I go. He goes, posture, which I know, he's like, I know a bunch of people laugh at that. He goes, I've been in practice for 40 years. He goes, you can't tell me you can sit around like this and then perform at your optimum if you don't think about that throughout the day. Cause then you think about it in golf posture, like everything else is posture driven. We're like, I can get away with this and do whatever. And like, which I get what he's saying. And, I can play on both sides of that. The next one would be breathing. The third one was mobility, which kind of plays into the FMS. Next one was stability. And he told a really interesting story, which I won't tell here, about Mick Fanning, a pro surfer, and kind of giving somebody more mobility that ended in a big injury because he didn't have enough time to work with them. But stability and then strength. This lady just never did the strength component. I'm not saying she breathes perfect or has the perfect posture, but she's really good, right? Top tier SMA, awesome. Balance was a little bit off. Can do a full deep squat. No pain. I mean, some of the rarities that we don't see. So great function. So no different than, somebody comes in, they're like, oh, I have Lyme disease. Like, do you or don't you? My first responsibility is, well, do I just use all my tools because that's what you expect? No. Yeah, I do some tool work and I'm like, you're going to do that. I do some stecco on your quad. You're going to start foaming on your quad, right? Like quick as I can, like hand it off. So it's not me, it's her. And they'll be like, yeah, you're doing awesome. Like get out of my office. like 3 visits, like bad business move, good business move long term. Um, and then being like unequivocal with your assessment because she was looking down the barrel of another surgery that was recommended. And I was like, I mean, you better be confident if you're like, no, that's a bad move. Cause I mean, then they go back to the surgeon. Let's say she gets hurt. She's going down her stairs, her knee pops, something. And then she's back in surgery. Like, I thought you told me I didn't need it. Like, well, yeah, based on all this information. And on another side note, case I talked about last time, a softball pitcher, low back pain. I pulled an X-ray on her 2 visits in because her mom was, I think we talked about this. She was complaining about pain with everything. Well, she ended up going to an ortho in between last podcast and this one. Ortho did an MRI, showed edema around the facet. So they shut her down. It's no different than what I thought it was. I just didn't think I needed to go far enough with the MRI because she seemed like she was doing okay. So obviously either something changed since I saw her or it was just a low enough level bother that they went to an ortho, and now I kind of look like I have a little bit of egg on my face because like, well, I thought you said nothing's going on. It's like, yeah, the X-ray showed nothing. If it's not bad enough for the X-ray and based on her pain level, I would keep going, which is exactly what I told him, saying that I was treating exactly what that MRI found, right? That the possibility of like a PARS injury, stress reaction, spondylolysis, whatever. So that being said, same thing with her. You run the risk of being like, oh yeah, something could happen, right? You could fall on your knee because her biggest thing that she still doesn't want to do is put pressure on that knee. Right? It's fake patella. I was like, that's where we got to go just from a tolerance standpoint to start loading that. So yeah, she's just kind of interesting. Like she had nothing wrong with her knee besides some numbness and like, yeah, stiffness in her quad, I guess. So going back to my stepmom for a second, had a full knee replacement. One of her biggest complaints wasn't her knee. It was actually her low back. So she is 6 weeks out now and has been walking on a walker, and that's protective so you don't fall and blow out your knee and stuff, and then going to PT. And we just talked to her a couple days ago, and like her biggest thing was like, I don't feel my back at all. So that's why we also try to make these decisions. I have a guy that's doing, or he did a consult yesterday, for which we talked about on here, of a hip replacement for low back pain. I'm curious to see what they said. I can imagine. But again, he called back in about his back and he's like, I really need to do something about this. So like, you can, but you need to work on your hip or have somebody fix your hip or change it. So yeah, same thing here. Just like being confident based on your assessment, not just kind of drawing straws, which again, I would say I'm at a 70% confidence interval with the whole Lyme disease conversation. Blackjack education. That's my little pet project with Dr. Audra Lance out of Nashville, Tennessee. And we have 2 great courses coming up for you in 2026. So we're kicking off the new year right with DNS golf right here in Birmingham, Alabama. 2 days at the farm, 1 day at Greystone Country Club. And we have Greg Rose coming in from TPI. We have Mark Blackburn, one of the best coaches in the world. We have Brett Winchester, the legend himself, and little old me will be helping teach a little bit as well. So you can go, again, blackjackeducation.com to check that out. Also, the last weekend in January, January 30th through February 1st, we have Dr. Richard Olm coming to Nashville, Tennessee for DNSB. So if you're looking to up your DNS game in 2026, the best bet in clinical education, blackjackeducation.com. Not super high, but it's above 50 for sure. So it's enough for me to talk about it and be like, hey, I think we need to address this. And then you bring me all the information, or I'd love to talk to your rheumatologist so I can learn more, right? Like maybe I don't know. Or maybe you talk to the rheumatologist and you're like, oh, I think what you're telling me is kind of hooey, right? And then you're like I've talked to orthopedic surgeons have told me stuff and I'm like, I don't agree with that at all. And some has been a good interaction where I told them that, and other ones, I'm thinking of one of our oldest patients, tennis player, it's now a photographer. You guys know what I'm talking about. His surgeon, we disagreed on because he wanted to do a surgery on his other hip. And I was like, prophylactically, I was like, what are we talking about? No, and great conversation, right? But I was unequivocal and like, no, I don't agree with that, and told him on. He's like, okay, cool. Versus like, no, I'm the surgeon, I'm right. It's like, if you get people that are willing to play, like, and I'll give a shout out and maybe we'll get him on the podcast, Dr. Matt Davis, like him and I have been working on more cases together just as of late too. And like, it's good to have dialogue where I send somebody I know what's going on, or he needs to manage, or I just sent somebody, I'm like, hey, I'm not quite sure what's going on. He came back with something. I'm going to be honest. I'm like, I don't know if that's it. We're getting further testing. We'll kind of find out maybe based on the test. But it's not bad to disagree. But if you get working with somebody, whether that's you as a patient working with a physician or a physician to physician, where it's more argumentative rather than conversational, I think that's a problem to a certain extent. I mean, if you feel like somebody is doing something wrong, obviously how you handle that's up to you. But any questions on our OG lady that needs to go do some split squats with some weights?
Speaking of like replacements, just in general, not necessarily her, people that have full or partial knee replacements, not wanting to put that knee on the ground. What are you doing for that?
Like, how am I getting there?
Yeah, because
I think
they're just like, it just hurts so bad to put that on the ground, and I'm like, okay.
I think the two things, she can't have any of that sensitivity around there, and that's going to drive it nuts. I mean, whether that's true nervy stuff or just like how you process it. I think one of the biggest things is, which I'm trying to think who said, like a lunge hold where your knee's floating off the ground is like one of the best isometric loads for like your quad tendon, and then like the top side, front leg quad tendon, backside like hip extender flexors, right? And just like hold that, and you're going to get a lot of bang for your buck. I think you could do that, and I bet you start to basically sensitize that body, because a lot of people have pain. Like she had some discomfort with that as the back leg in a split squat.
Yeah.
Nothing in the front. We could load her knees over toes style, whatever you're going to call it. And like she puts the back leg, she's like, that's probably how they're loading stuff or have forever. And I'd be like, hey, that's what we're going to sensitize. And then I'd have her not like kneel in like a lunge. I'd have her start sitting back on her heels. So we're still in full knee flexion to hang on to that. And then there's a little less just like compression on your kneecap because you're like whole shins loaded. And then work her back up into quadruped or whatever we do there. Because I told her I'm going to do that. Like last time when who was in there with me, and she's like, I said, well, how is it getting down on your knees? She goes, oh, I still want to do that. I go, okay, well, we're going to do that when you come in next time.
That's the biggest thing is I like every patient I have that has a knee replacement, they're like, my surgeon told me do not put any weight on this knee. Like, don't kneel on it.
The reason they say that is like, and I don't disagree with this, like not an easy way, a way to dislocate a knee that has dysplastic change or a shallow groove in the trochlea or whatever is to basically be on it and then pivot while with which should make sense. I mean, that's how we relocate it. You're going to basically like push it in. So that's what they're saying is we wouldn't want somebody to like be on it and then reach for something. You literally like push it, over the trochlea. I don't disagree with that. That's no different than what do they tell people with hip replacements? Don't cross your leg. I mean, I get the abduction. They think that you're going to have this like anterior inferior dislocation in your hip. Huh?
Maybe in a window after the surgery.
Yeah, you're 100% like, yeah.
Or if you do a very aggressive Faber on somebody, I mean, okay. But
I think of one of our good friends and a patient that had a hip replacement years ago and then just had another one on the other hip. He was a professional ice skater forever and doesn't like that position. But he's like, oh, I do this all the time. It's not that I just don't do it. He goes, it just feels weird. And maybe that's what he was told. Yeah. But he's doing all sorts of crazy stuff that's putting him in positions that are that. And then we think, oh, I can't do this, which is silly.
Yeah.
He'll be out there cutting down trees and he's probably got one leg up on a log and he's bending over and it's in big loaded abduction flexion. And then maybe I'm not saying him gets coached like, when I'm hanging around, I just can't cross my leg. And you're like, that's the silliest thing I've ever heard.
Yeah, it seems like you'd want to meet somewhere in the middle. You might not have them doing that right after the surgery,
or they're not doing yoga poses like lotus or frog sits. You're like, yeah, we're just not going to push you there.
Yeah,
but you
to
can
say
do that.
You're never going to do it. Then you create another problem.
100%.
Because you just expect to never grab something off.
Yeah.
Or have to do it a different way for the rest of your life.
And that's why I tell all my patients that go into a replacement surgery to make sure they know what the expected range of motion norm is after surgery. Not everybody's the same. So again, based on how your knee is before you get a knee replacement, how deep your hip has to have, like all these things matter because some people will have full abduction, some wouldn't. And then to think like, oh, I'm going to push them there. You don't know the shape of their hip, which way their pelvis is rotated, like, from a true torsion standpoint. And then we're maybe the dummy, they're like, oh, this side's perfect. That was a non-operable. We get over here and they're a year out and they're like, oh, they have 45 degrees. And you're like, we can do some stuff for that. And you're like butting right up against the joint surface, right? Which you should be able to feel from palpation. So yeah, it's just, again, goes back to assessment. Like what's the norm? But some of that you got to rely on from the surgeon because you're literally the prosthesis itself is determining that for sure. Yeah. Any other questions or ideas, thoughts?
I guess I just think it's important to know, especially for the young people out there, just like, so like after the surgery, people go to PT, but just to ask, like, what did you do in PT?
Mm-hmm.
Because, I think we've seen a lot of people lately where they're just not loaded enough, especially for like their daily living. And that's truly what they need is just to be pushed farther. So not saying that PT did a bad job. Maybe they just ran out of visits. The
which is the
scheduling
typical
conflict,
one,
but
whole problem in
they
itself.
just needed more for being a active individual.
Yeah, I'd say the most common thing I hear, I'm sure you guys hear it too, is we ran out of visits, so this is what they left me with. And then they hand them a big sheet of exercise, which they don't do. The other question I ask is, what was your return to play criteria, or like return to life stuff? Most people, none, which is wild, because if there's one profession that's supposed to hinge on that, because they're literally following the white paper of like, this is how you treat Achilles tendinopathy or post ACL, it's like, you should be able to do X, Y, Z. And you just see a lot of people like, they don't ever get that. So if I had like my patient, elderly patient, physically active, they're going to go back to it. Like I told her, like, why? I just can't imagine that somebody's going to put somebody on like, a bike and make them ride for 20 minutes, do general range of motion stuff, very low level exercises like body weight. And then they never do like a Wingate test, literally stepping up and down to see like, how's your aerobic capacity match your ability to move around your knee, which now was her problem going up downstairs. I'm like, that's just ridiculous. Like, can you do it? What was your rating? Which we have all that, standardized. And then like, did you have pain? Like just that simple thing would like give us a good thing. I was like, hey, can you keep walking? Right. And then can you do some step ups? That might be better than just whatever they sent her home with or nothing. So, which is still a low level, but it's better than nothing. And it's based on something. It's not just the protocol.
Which that's why we also talk about a ton in here is like, yeah, after surgery, I want you going to PT so they can do some of the not fun stuff. But after like 4 weeks or so, like hop back in here and let's just see and almost have a conversation of like, what are you doing? How are you doing them? Make sure you just have a check-in and be like, they're doing great. They can continue with whatever they're doing. Or like we've mentioned before, they need to tweak one exercise, one little thing, because maybe the PT is just like super full. They're super busy, may not be able to put an eye-to-eye contact on what they're doing. You switch one little technique and then like, hey, continue doing that exercise just with this cue. And then they're like, that's where they could like start getting a lot better very quickly.
What I'm paying with broad strokes, and I say this, but like post-op PT or outpatient PT for the most part to me is quantitative. Like we're trying to be more qualitative. Like we're trying to say like, yeah, it's great to do split squats. You could also do a split squat and start driving your knee nuts. But some people are like, oh no, it's, form's not that important. Just low. Like, no, come on. Yeah, I don't agree with that at all. So we're the qualitative, especially in that like 4 to 6 week. We're saying that in general, right? Big difference based on what's going on. But to see like, hey, you're doing this, and it's like, God, you're not loading your foot. Like you're just leaning on the outside of your foot when you do whatever, right? Like be like, oh, that's not awesome, right? It's going to show up later with something, we'd assume. But I think people would disagree with us. But I'm just, I'll stand on that soapbox. But the further you go through PT, the more qualitative it should become because you're able to do more, right? So it's not just range of motion, it's quantitative, right? Your ability to whatever we're going off like a Cybex or quad sets, that's pretty quantitative still because it's a certain amount of like sets and reps and weight that they're trying to get them to before they're like, now it's big movements. Now, how do you do a lunge, right? Or how you stand on one leg or whatever it is. Yeah, I don't disagree with that at all. But that's what I'd like to see more of. And it's not saying, and again, broad strokes, not saying that some PTs aren't doing that, especially maybe even in the outpatient setting. But if you have 6 people that you're running through protocols, moving from like hand ergs to the table and doing some soft tissue, and then you have a PTA doing it, I'm not blaming you, but like it's going to be harder in a fast food style to have quality versus like a one-on-one. I mean, that's no different than a higher end restaurant. That's why it's different. So that's my take. Anything else? Knees. All right. How many more do we got? This is 49. We got like 6 more episodes we can review in this season.
Does that take us to the end of the year? Is that where we're trying to go?
It goes through January a little bit because I had 10 of each. But we got some cool guests coming up. So like I said, I already did the Tim Brown podcast. We got Clay Gasparovich, good friend of mine, DC coming out on the docket. We got Courtney Conley. We got Dr. Clayton Skaggs. We got hopefully Dr. Matt Davis, orthopedic surgeon here locally. And then I'm going to finish it up with like a wrap-up show at the end of the season. So yeah, a lot of stuff coming. And I think we're going to talked about it quite a bit today. I wanted to talk about functional medicine cases, not where it's a whole functional medicine case, musculoskeletal, where functional medicine became the bigger part of it. So I think that's what next show will be, but we'll see. See you guys next time.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.